Hello everyone, welcome to today's lesson with calebmulonga. Happy New Year, welcome to the New Year. So today we are looking at nursing care plan for burns in pediatrics. So this is it was one of the questions in the 2025 November pediatrics paper 1 in nursing. So let me just read out the question so that we can dive right in. So the question reads, Joseph, aged 2 years and weighing 12 kg, is brought to your children's ward, where you are working from with 20% bends involving the anterior trunk and the upper limb. So things to consider, there is anterior trunk and upper right upper limb. So those two are very important in the management. Then the question C is identify 5 problems that Joseph may have and use the nursing care plan to nurse him. So if you look at that, we are using the nursing care plan. So just look at this. Firstly, it is unusual, not that common, to talk about burns in pediatrics, but they do happen. So quite a number of people were confused. So here we have to consider the child is 2 years old and has 20% burns over the upper trunk and the right upper limb. So before we go into details, don't forget to subscribe, like, and share. Okay, so we start with assessment. If you've been on this channel, you understand that we always start the nursing care plan with assessment. So the first thing is we assess. So if this child has burns of the upper trunk, it means that it may interfere with the breathing of the child. It will interfere, in fact. So if the child's breathing is interfered or the child is not breathing properly, so our problem is going to be ineffective breathing pattern. Therefore, our first problem is ineffective breathing pattern. The nursing diagnosis, ineffective breathing pattern related to bends of the anterior trunk. Secondary to, or you can say related to, inflammation and swelling of the chest, secondary to bends on the upper trunk. So here the thing is there are bends on the anterior trunk. And that because of that, you find that there will be inflammation and swelling, and this will result in difficulties in breathing. Evidenced by difficulties in breathing or dyspnea. Goal. The goal is to improve the breathing pattern within 30 minutes of hospitalization. So remember, the goal has to be SMART. And it has to be, so SMART means sustainable, measurable, attainable, relatable, and time-bound. So it has to be SMART. Let's look at the interventions. So here you have to be very careful because these interventions are for a 2-year-old. So number one, we are going to say I will monitor the respiratory rate or the respiration rate to detect any signs of respiratory distress, such as dyspnea or tachycardia. Number two, I will administer supplemental oxygen to improve tissue perfusion and oxygen saturation. Number three, I will check the oxygen saturations using a pulse oximeter to assess oxygen saturations and monitor the patient's response to oxygen. So probably we understand that this is the point we usually put as I will monitor oxygen saturations using a pulse oximeter to note whether the oxygen saturations are above 90% or below, and give supplemental oxygen if below 90%. The fourth one is I'll prompt up the patient to promote lung expansion. So if you've noticed the patient is having difficulties in breathing, but I've not rushed to say, put the patient in semi-fowlers because this is a 2-year-old. So the best thing that we can do is put this child in a prompt up position, or to prompt up the child, meaning we just put pillows. Okay, we put pillows behind where they are sleeping so that they are elevated, and this will help lung expansion. Elevation. So that is what we want to do. We want to elevate the child. So evaluation, the patient had normal breathing within 30 minutes of hospitalization, evidenced by normal respirations of 24 breaths per minute. So this is a child. Respiratory, normal respirations in a child differ, but looking at the age, it's somewhere at 24, somewhere to 35 or 40. So 24 is okay. Okay, we move to the second one, which is fluid volume deficit. So because this patient has burns, these burns have removed the skin. There's exposure of the skin, or the internal organs have been exposed because the skin has been removed. So what happens is that, remember, one of the functions of the skin is that it helps in maintaining a fluid balance. So because the skin is no longer there, we can lose more and more heat and water through evaporation. So that is why we are having fluid volume deficit. Therefore, problem is fluid volume deficit. Diagnosis is fluid volume deficit related to electrolyte imbalance and excessive fluid loss through evaporation from the wound or from the exposed skin, evidenced by sunken eyes and poor urine output. So that is straightforward. So the fluid volume deficit is as a result of the exposed wound or the skin area that has been bent, and we lose water and electrolytes. Go. What we want to do is to replace the lost fluids and electrolytes within 24 hours of hospitalization. So remember, there is what we call a Parkland's formula. This is one of the formulas that we use in the management of burns. So usually it takes 10 to 24 hours for 24 hours. So the goal is basically to replace the lost fluids and electrolytes within 24 hours. Let's look at the interventions. Number one, I will cannulate the patient or the child for intravenous access or fluid administration. Number two, I will initiate intravenous fluids therapy according to the Parkland's formula by giving Ringer's lactate or normal saline to replace lost fluids and electrolytes. So remember, what we want to do is replace the fluids. So we are just going to say, I will administer normal saline or Ringer's lactate according to Parkland's formula to replace fluids and electrolytes. Number three, I will monitor and document fluid intake and output using a fluid balance chart to prevent overhydration, or you can say to prevent complications such as hypovolemia and renal failure. So both are okay. Number three, I will monitor the pulse to detect any signs of hypovolemia or hypovolemia. So a pulse is a good indicator to show shock, which can indicate for shock. So the pulse and the blood pressure are good indicators, but since this is a child, we will mostly focus on the pulse. So if we note that this child is having a very high pulse, it may signify to say they may be going in hypovolemic shock. And the last one, we can say I will assess the hydration status. I'll assess the hydration status by checking the skin tagger, increase in pulse, decreased urine output, or change in the mental status, or excessive pulmonary congestion or pulmonary edema to recognize appropriate fluid balance. So basically, this point is just saying that I will assess the hydration status to note if the patient is being hydrated or not, or to note if the condition is improving, because our goal is to monitor whether we are replacing enough fluids. So here what we can do is just to assess the signs of dehydration. Okay, so the signs of dehydration, poor skin tagger, increase in pulse, decreased urine output, all those will just help us to rule out dehydration or to note if the condition is improving. The evaluation is patient was adequately rehydrated in 24 hours, evidenced by normal urine output and normal urine output and pulse within the normal ranges. We move to the third point. So these are bends, and it's about 20%. So there is a high chance that there is pain. There is pain because of burning or exposure of the nerve endings. So the third problem is pain. In the bends is pain. So pain, the nursing diagnosis is pain related to exposed nerve endings and inflammatory process, evidenced by verbalization and patient crying or child crying. So the baby can be saying it hurts and they can be crying. So that can be evidence enough to show that they are in a pain. Why is the pain coming from? It is because the nerve endings are exposed and because of the inflammatory process. Go to relieve pain within 2 hours of my nursing interventions. So this can be 1 hour, can be 2 hours, but it can't be beyond 2 hours. So at least 1 hour. Let's look at the nursing interventions. Number 1. Of course, the first one, you assess the pain levels, but this is a child. So that is not really dependable. But we can do other things here. Firstly, what we can do is use a bed cradle to lift the weight of the linen off the bends, therefore relieving pain or preventing pain. So remember, the patient has bends on the chest, on the anterior trunk, and the right upper limb. So what we can do, we can use a bed cradle to lift the linen off the skin or the bent area. Number 2, I'll provide diversional therapy such as switching on a television set or radio to divert the child's mind from pain, therefore relieve pain. Number 3, I'll administer analgesics to block pain receptors and interfere with pain transmission processes. Basically, this point is saying I'll administer analgesics to relieve pain. Number 4, I will use the unaffected area of the patient for positioning to prevent pressure and irritation from the bent area, therefore relieve pain. So here what we are doing is allowing the child to sleep or to lie on the area that is not affected. This will help in the relieving of pain. Evaluation. Patient was Pain was relieved in 2 hours of nurse care, evidenced by verbalization and the baby minimizing on crying or not crying. So just like that, we have managed to come up with 3 problems. The fourth problem is that because the skin is exposed, because the skin has been removed, has been bent, it means that there is a high chance of heat loss through evaporation, just like the person was losing a lot of water through evaporation. There's a high chance that they are losing heat also. So in burns, there is no fever. There is hypothermia. There is reduced temperature because of the exposed skin. They will lose a lot of heat through vapor. So outer thermoregulation, which is hypothermia. Outer thermoregulation, hypothermia related to heat loss through exposed skin evidenced by body temperature below normal range, which is 35.5 degrees Celsius. So we are saying this child will have a body temperature, let's say, which is 34 degrees Celsius. The goal is to restore the body temperature to within normal ranges of between 35.5 degrees Celsius to 37.5 degrees Celsius in the first 2 hours of hospitalization. So fever is very important in a child. The goal should not exceed 2 hours. The best can even be an hour, because in a child, you do not control this temperature. In this case, it's not fever, it's hypothermia. But it is very important to control it. Temperature is very important to control in a child. Okay, let's look at the interventions. Number 1, I'll nurse the child in a patient. I'll nurse the patient in a well-heated room by using heaters and open and keep windows closed to conserve some heat or to promote warmth and therefore restore the body temperature. Okay, that's the first thing. We want to ensure that the child is being nursed in a well-heated room. Number 2, I'll keep the patient warm by covering him with adequate blankets to trap the heat to restore body temperature. That's basically the rationale. Number 3, I'll keep the linen dry to prevent heat loss by conduction. So you make sure that whenever the linen is soiled or wet, the linen is changed so that the child is sleeping on fresh, dry linen. Number 4, I'll monitor temperature half hourly to identify and treat hypothermia. Okay, so those are some of the interventions. Of course, we also have hot water bottles. So I'll use a hot water bottle when nursing the child to promote warmth. All those things can be present as we nurse the child. Let's look at the evaluation. Normal body temperature restored, evidenced by no patient or a child having a temperature reading of 36.7 degrees Celsius. So just like that, we have managed to nurse this child with burns presenting with hypothermia. So do not put hypothermia as a problem. Okay, so since the skin is exposed, and remember, one of the functions of the skin is that it is there to be the primary or the first line of defense. So once it is removed, the person has an increased risk of having infection. So therefore, once it is removed, it means that this person is at a high risk of having an infection. So risk for infection is another problem. So this is a risk. So risk for infection related to loss of skin barrier and altered immune response. Of course, the goal to prevent infection in the first, to prevent infection throughout hospitalization. So we want to prevent infection throughout hospitalization. So let's look at the interventions. Number one, I will use antiseptic techniques in the patient care to prevent the growth of microbes on the wound area, or you can just say I'll use antiseptic techniques such as washing hands before and after taking care of the patient to prevent infection. Number two, I'll change sewed linen frequently to avoid contaminating the wound, therefore prevent infection. Number three, I will monitor temperature 4-hourly to detect any fever which may be a sign of infection. So here we are going to monitor temperature to detect any fever. If present, it may indicate infection. Number four, we can also administer prophylactic antibiotics to combat or prevent infection. The other thing that we can do here is we can also isolate this child. So you find that we can isolate this child to prevent exposure of this child to infection. The other thing that we can do is ensure that any patient or any person rather attending to this patient does not or is not having any flu or any sort of infection that can be easily transmitted to the child. And by doing that, we prevent infection. So here the difference is that we are not preventing the spread of infection. No, we are preventing the child from acquiring infection. So this is why I ask you, are we using barrier nursing or reverse barrier nursing? You can comment in the comment section so that we can educate each other. Okay, evaluation. Infection prevented throughout hospitalization evidenced by a clean wound with normal body temperature of 36.7 degrees Celsius. So those are about 5 problems, but we also have one more, which is a bonus because it's New Year. So our last problem is risk for altered nutritional status less than body requirement. Why is this a risk? It is because this child is in pain and will not be able to eat. Okay, this child will be in pain and will not be able to eat. So it is more of a risk than an actual problem. But I do not have a problem if you put an actual problem for altered nutritional status. But here it is a risk because of the problems that I've stated. So risk for altered nutritional status less than body requirements related to anorexia, secondary to pain, or dinophagia, which is basically painful swallowing. So dysphagia is difficulties in swallowing. Dinophagia is painful swallowing. So this child has no appetite because of the pain they're going through, but because the area of the chest that has been bent is closer to the neck, you find that there can be some sort of difficulties in breathing. But to be very careful or to be specific, the pain, the anorexia is as a result of the pain that the child is in. Okay, let's look at the goal. The goal is to maintain a good nutritional status in the first 72 hours of hospitalization. So this is not something you can achieve in 1 day, 2 days, at least 3, 1 week. So even if you put throughout hospitalization, it is okay. In fact, that is what I prefer. Okay, let's look at the interventions. Number 1, I will maintain NGT fluids as the patient cannot easily swallow to supply high nutritive needs, feeds 3 hourly. So this point, to be specific, especially this one, for risk of outer nutritional status, I added it if this child is having difficulties mostly to eat, or they're having pain when eating. That means that the neck is involved. Get that straight. If the neck is involved, let's say the neck has been bent, you are going to put an NGT tube. But if, just like the question said, there was no mention of the neck, you are not putting NGT. You are not feeding the child using an NGT. You are not. So that is an emphasis that I have to make. I have put this point because I am explaining to say, if the neck has been involved, meaning the bends of the neck are present, on the neck are present. Okay, other interventions include, I'll give the patient small frequent feeds to promote appetite. Okay, that we know. Number 3, I'll provide a high protein diet, high fiber diet, in order to provide the patient with nutrients necessary for wound healing. Number 4, I will give the patient a choice of food, their choice of food to promote adequate intake. So you give the patient the food that they want. For example, this is a child, this is no, me, I want chicken. Tell their parents to bring chicken, then they eat. Then the last one we can say, I will give adequate fluids, where I'll give adequate fluids to replace lost fluids and aid in digestion, therefore helping or maintaining a good nutritional status. So before I forget, on fluid volume deficit, we did not put oral feeds. So on fluid volume deficit, we did not put oral feeds. So you can add that one. We say, I will give oral fluids such as water to promote good or to promote hydration. Okay, so I would like to know other problems that we have, but before that, let us evaluate this problem. So the evaluation is the patient's nutritional status has been maintained in the first 72 hours, evidenced by optimal weight with reduced pain on swallowing. So basically, the evidence is that the child has maintained a good weight. So remember, the last problem is present because of the involvement of the neck. If the question has not involved the neck, some of these points may not be present there. Okay, thank you for staying with us. We've come to the end of the lesson. Don't forget to share, like, comment, and subscribe. Thank you for everything. Happy New Year to everyone. See you next time. God bless you.